Hey guys, welcome back. My name is Akanksha Jain. I'm your clinical psychology educator, and this video is brought to you by Cyclothymic. I hope you're all doing well and you all attempted the mock test for the previous sessions. Now, as usual, before starting today's lecture, we will be doing a quick revision of whatever we covered in the last session. So in the last session, we discussed mood disorders, depressive disorders, and bipolar disorders. We started with what is mood versus emotion. We learned that emotions are short-lived while mood is longer, persistent, based on duration, severity, impairment. We decide whether it could turn into a disorder or not. Then we discussed the first depressive disorder, that was major depressive disorder, where we said there should be at least 5 symptoms out of the 9 symptoms, and one of those symptoms should be either depressed mood or loss of interest or anhedonia. We remember this by SIGECAPS, SIGCAPS. Then we also talked about it should be at least 2 weeks and there should be some kind of distress or impairment present. We also talked about some of the specifiers like melancholic, peripartum, atypical, seasonal, psychotic features, and others. Then we talked about persistent depressive disorder, also known as dysthymia. We said that this is less severe but more chronic. Okay, we said that in adults it should at least be for more than 2 years, and in children at least more than 1 year. We also said that this person who is diagnosed with PDD should not be symptom free for more than 2 months. Then we moved on to other disorders like DMDD, where you talked about it is only from 6 to 18 years, and it talks about temper outbursts. We talked about PMDD, severe form of PMS. It should be in luteal phase of the menstruation cycle, and at least there should be more than at least 5 symptoms. Then we moved on to what is mania. We remember the symptoms of mania by DIGFAST, DIGFAST. We remember that at least 3 or more symptoms should be present. If the mood is elevated, expansive, hospitalization is required, there is severe impairment. But if the mood is only irritable, we require at least more than 4 symptoms. For how much long? For at least more than 7 days. And again, impairment or hospitalization, that means it's directly mania. Hypomania, 4 consecutive days, less intense, and there is not that severe or maybe it's like no impairment of the daily functioning. And we talked about bipolar 1. So bipolar 1, the requirement is at least 1 manic episode. If there is even 1 manic episode, it is directly bipolar 1. But for bipolar 2, we require 1 hypomanic episode and 1 depressive episode. 1 hypomanic, 1 depressive, and absence of a manic episode. Okay, then we talked about mixed, when depressive symptoms and manic symptoms occur together. Now, it could be depressive with at least 3 features of manic episode, or it could be manic with at least 3 features of depressive episode. Okay, then we talked about cyclothymia. That is when it does not meet the criteria of either manic episode, depressive episode, or hypomania, and it is persistent for more than 2 years in adults and more than 1 year in children. Then we also talked about its etiology. Why does mood disorders even occur? We talked about biological reasons. We talked about neurotransmitter imbalances. We talked about brain functions, brain structures in prefrontal cortex, hippocampus, amygdala, things like that. We also talked about how it is biological factors, psychological factors, and social factors that come together. So from that, we moved on to psychological theories. We talked about Beck's theory. We talked about learned helplessness theory by Martin Seligman. We also talked about behavioral activation. We also talked about some important assessments like PHQ-9, BDI-2, HAM-D, YMRS. And then we moved on to treatments where we talked about antidepressants, mood stabilizers, and then psychotherapies like CBT, IPP. Also talked about when we use electroconvulsion therapy, and obviously it comes with lifestyle modifications and psychoeducation. Also, we also talked about that we do not give antidepressant monotherapy in the case of manic symptoms because it can elevate it. Remember the durations and the number of symptoms. It is very important when it comes to UGC NET and CUET PG program. Okay, now that we have revised whatever we have done, remember that if you would like detailed notes that are concise, that are beautiful, packed with mnemonics and examples which can help you remember everything very easily, you can find the link in the description below. Okay, great. Now let's focus on what we are going to cover in today's journey. We are done till mood disorders. Today we will be covering anxiety disorders, OCD spectrum disorders, as well as trauma and stressor related disorders. Again, the same, we'll talk about some of the assessments, some of the treatments, and we'll solve some MCQs. Okay, great. Now, let's have an overview of what anxiety disorders have. Okay, so there are 7 disorders that comes under anxiety disorders according to DSM-5 TR. The first is generalized anxiety disorder. Second is panic disorder. Third is agoraphobia. Fourth is specific phobia. Fifth is social anxiety disorder. Sixth is separation anxiety disorder. And seventh is selective mutism. We'll discuss all of this in detail. But before we discuss all of these disorders in details, there is one basic thing that we need to understand: what actually the term anxiety means, right? And how is it different from the term fear? So, normal in a very everyday life, we tend to use these two terms very interchangeably. But are they interchangeable, especially when it comes to DSM and disorders? No, they are not. They hold actually very distinct meaning. So what is the difference? Let's talk about fear first. Okay, fear is an emotional response. Emotional response to what? To any immediate, real or perceived threat. When does this immediate, real and or perceived threat occurs? Right now. That is the important part. So, if a dog is chasing you and then, your heartbeat starts to increase, you sweat, you are having breathing issues, and then you decide either a fight or flight response, right? That is fear. That is for the present moment. There is an immediate danger, there is a real danger or even perceived danger if the dog is just, barking at you. Okay, that is fear. So, fear is always, remember, for the word you have to remember is present danger. Present danger, immediate danger. On the other hand, when we talk about anxiety, anxiety is an anticipation of a future event. What do we mean by anticipation? So that event is nowhere near us. Okay, we don't even know that it will happen or it won't happen. We are basically worrying about something that might happen, that might even not happen. So it's always, waiting and worrying about something that is a future possibility. So anxiety is always about what? Future possibility. These two terms you always remember: present danger for fear and future possibility for anxiety. That is how you differentiate between anxiety and fear. Okay, now let's look into what changes has happened in DSM from DSM-4 to DSM-5. Okay, so one of the things that we can see a major change is, before DSM-5, we used to have anxiety disorders, OCD disorders and PTSD all grouped together. Why? Because there's a common feature, that is anxiety. But DSM-5 made these 3 different chapters. Why did it do that? Why did they feel the need to differentiate the chapters? That is because while they have a common feature known as anxiety, the underlying mechanisms, the symptoms, the patterns, even the treatment approaches were absolutely totally different. Let's talk about anxiety. Anxiety is more about fear and anxious symptoms. While when we talk about OCD, the core symptom that comes there is obsession and compulsion. When we talk about PTSD, it has a very main criteria, that is, it always happens after exposure to a trauma. So, let's just say, although all of these have anxiety, the core symptoms, the hallmark of these disorders are different. Now, tell me one thing. If there is an exam next month and you are constantly worrying about that you will fail that exam, is it anxiety or fear? It would be anxiety. Why? Because if my exam is right now and I'm tensed about it, that might be fear. Because I don't know, the questions are in front of me and I don't know those. That could be fear. But an exam is next month, I'm already prepared for it, but I'm still worrying about that I'll fail in this exam. That's anxiety. Okay, great. Now that we are clear with what anxiety is, let's understand some basic symptoms that is across all the anxiety disorders that would keep on repeating. So what we are going to do is we are going to sort it out once. Okay, so that we just have to focus on the major part of each disorder. So let's talk about some common clinical features. Right, so regardless of the specific diagnostic, most of the anxiety disorders share some common clinical features. The first is excessive fear or anxiety, excessive worry, okay, which is much greater than what the situation actually demands. The second would be avoidance. The second is avoidance. Avoiding what? So what people do is since they worry so much about that situation, they tend to begin avoiding that situation that could trigger the anxiety. What happens when you avoid the situation? It provides you with temporary relief that could actually maintain the disorder over the time. Another important feature is physiological arousal. What do we mean by physiological arousal? Any symptom like increasing of your heartbeat, sweating, muscle tension, trembling, dizziness, even shortness of breath. These are all physiological symptoms. Then finally, these symptoms have to be clinically significant. That means it should cause some kind of functional impairment. Okay, some kind of impairment in your relationships. It should interfere with your work, with your studies, with your daily function. Basically, that is what qualifies it to be an anxiety disorder. Okay. Now, remember, feeling anxious is completely normal. It becomes a disorder when it is excessive, it is persistent, and it starts affecting your daily life. So, if someone feels anxious before an interview, do they have an anxiety disorder? Not necessarily. Anxiety becomes a disorder again when it's excessive, persistent, and causes significant impairment. That is the difference between a normal anxiety and a pathological anxiety. Okay, great. Let's look into etiology. Now, as we have always discussed, there is not one factor or one cause that causes any kind of disorder. We have always explained it using biopsychosocial model. It includes 3 factors: biological factors, it could be genetic vulnerability, neurotransmitter imbalances, or overactivity of brain lesions like the amygdala. And then we have psychological factors. It could be personality traits, it could be previous learning experiences, or maladaptive coping mechanism, thinking patterns. Then we have social or environmental factors, stressful life events, childhood trauma, family conflict, chronic stress, anything. So it is the interaction between all these 3 factors. Now let's move on to the general assessment approach. Now we have already discussed this in module 1, and with all the disorders that we follow a similar pattern. So even when a client presents with anxiety, its diagnosis is never based on just one questionnaire. We start with a detailed clinical interview, MSc, then appropriate scale. You use appropriate scales, and then that can help us to assess the severity, monitor the progress during the treatment. Again, assessments never replace the clinical judgment. Okay, then what is the general treatment principles? So treatment usually depends on the severity of the symptoms. Okay, for mild to moderate, we could just go with the CBT, which is the first line psychological treatment when it comes to anxiety disorders. CBT, first line psychological treatment when it comes to CBT. Okay. But when the symptoms are more severe, or it is actually significantly impairing your daily functioning, medications like SSRIs can also be prescribed. We'll look into that a little more. Okay. Now, let's move on to the first disorder, right? The most common disorder that we discuss, which is known as generalized anxiety disorder, GAD. Okay, and also frequently asked in examinations, so please focus. Okay, great. So generalized anxiety disorder is characterized by, again, persistent, excessive, and difficult to control worry about multiple areas of the life. The term that you need to focus here is itself in the name. Okay, that is generalized. That is the word you focus on. Why? Because the anxiety is not limited to one situation, one object, or one event. Instead, the person is worrying about everything, whether it's their health, their family, their work, their studies, their finances, their relationships, every small day-to-day situation. And the worry also tends to, shift. Once a concern is resolved, they'll immediately move on to something else. So, let's imagine a student who is preparing for an exam, for an entrance exam. So instead of only worrying about the exam, which was obviously very normal, they'll constantly think, what if I fail? What if my parents are disappointed? What if I never get admission? What if, I took this field and I can't even build a career out of it? Even when they're studying well, they're continuously worrying about it. At night, they replay these thoughts repeatedly. They struggle to sleep, they are restless, they cannot concentrate, things like that. So that is how persistent, excessive, and uncontrollable anxiety, which is called as GAD, looks like in real life. Now that we have talked about how it looks like, is it enough? We also need to decide a duration. This could always, just be for one day as well. Is it GAD then? No, it's not. So 6 months. These symptoms should at least last for 6 months. It should be present for most days for at least these months. Okay. Now, you can also see the clinical vignette we have discussed here. Ria, a 28-year-old marketing executive, worries excessively about her work performance, upcoming presentations, family health, and finances. She finds it hard to relax, feels constantly on edge, gets tired easily, and has trouble sleeping. These worries have been going on for more than 6 months and affect their daily life. There is impairment, there is the duration, and there is also the clinical picture we talked about. Okay, now actually let's look into what the DSM criteria actually says, because that is very important. So whenever you see a case where a person is worrying about multiple unrelated areas of life for at least 6 months, and that worry is very difficult to control, the first thing that should cross our mind is generalized anxiety disorder, and then they also have to check for what is not present. There should be no panic attacks, no specific phobia, no traumatic event that, which happened before these anxious symptoms started to, arise. It should be just excessive and free-floating worry. Okay. So what are the criteria? Okay, let's focus on the first criterion, excessive anxiety and worry. Excessive anxiety and worry, what do we mean by this? This should be out of proportion, that is required out of the situation. Out of proportion of what is actually required out of the situation. Okay, and it should happen in a number of activities, number of events, like focus on number of events, because it shouldn't be in just one area. Like, I just get anxious about my work, but when it comes to my personal life, when it comes to my health, when it comes to my finances, I do not worry at all. Then it's not there, because it should be generalized. Okay, so this is what actually differentiates it from the other anxiety disorders as well. Okay, the criterion B is difficult to control. The person really tries to stop worrying but simply cannot. There is this inability to switch off. That is a hallmark of GAD. Okay, and the third criterion talks about associated symptoms. So the associated symptoms we have talked about 6 symptoms here. Okay, 3 or more symptoms should be present. How could you remember this? You can remember this with REST MI. Rest MI. Okay. R is restlessness or feeling keyed up. Okay. E is easily fatigued. S is sleep disturbances. T is trouble concentrating. M is muscle tension, and I is irritability. Being cranky. Do not memorize it. Just think of a person who is constantly worried, and you require at least 3 out of these 6 symptoms. But when it comes to children, this is for adults. For children, we need only 1 symptom. 1 symptom for children. Okay. There is also criterion D, that it should be a clinically, significant distress, and it should cause some kind of impairment in important areas of the functioning. And there is also criterion E that says that it should not be explained by any other medical conditions like substance use or any other mental health disorder. Let's also, quickly talk about some of the assessment scales that you have to look into. That is GAD-7. Okay, it's a brief self-report questionnaire used in clinics, primary care. Then we have HAMA, which is Hamilton Anxiety Rating Scale. This is clinician administered. Okay, and it assesses the severity of the anxiety. Okay. And then we have Dugas's Intolerance of Uncertainty Scale. This is based on Dugas's Intolerance of Uncertainty model. What does this model talk about? This is one of the cognitive explanations of GAD. According to this theory, individuals with GAD find uncertainty extremely uncomfortable. Any kind of uncertain feeling, even when nothing is wrong, the uncertainty in itself creates the feeling of anxiety. For example, instead of, waiting calmly for exam results, they keep on thinking, what if I fail? What if I, something goes wrong? What if, there is just some error from their end, but it cannot be resolved? So it's not the event in itself, it's the inability to, to tolerate the uncertainty that actually fuels the worry itself. Okay, now let's move on to the next disorder. That is panic disorder. When we talk about panic disorder, in GAD, there was anxiety which was chronic. It persisted over months. But panic disorder is actually sudden. It's intense episodes of fears known as panic attacks. So let's look into it a little detail. Let's start with the definition itself. So panic disorder is characterized by recurrent, unexpected panic attacks followed by persistent concern about having more attacks or significant changes in behavior to avoid them itself. So there are three things that we need to focus on. First is recurrent. Second is unexpected. Okay. The attacks occur repeatedly and is not always triggered by a specific situation. It could be different situations that trigger it. They can happen while driving, while shopping, while you're watching TV, even sometimes during sleep. And then the term unexpected is because it is happening anywhere. Then also we need to notice is the term persistent. What do you mean by persistent? Persistent here we're talking about anticipatory anxiety. Okay, we'll look into that. But before that, we're talking about panic attacks. So what is a panic attack? Now, panic attack is a sudden urge or, a sudden surge in your fear, intense discomfort, which reaches peak within minutes. It's not building up. It just builds up in a minute. It's not like it is happening for the whole day or for some weeks. It just builds up in minutes. Okay, how do you feel in those minutes? You can feel palpitations, sweating, trembling, shortness of breath, chest pain, dizziness. You feel like you're dying or you feel like you're losing control. In fact, these symptoms resemble to a heart attack so much that many people rush to emergency department during their first panic attacks. That is why panic disorder is actually seen way more in general medical settings than psychiatric clinics. Now, we talked about persistent concern. We said that it is anticipatory anxiety. What do we mean by that? After experiencing one attack, the person becomes constantly worried about what happened and to not trigger it and when the next one might happen. They start to avoid any situations where another attack could occur. For example, someone who had a panic attack when they were shopping in a shopping mall, they may even stop to going to shopping malls altogether because they're afraid of having another panic attack, not of the mall, but the panic attack that happened there. That fear of having the panic attack itself is anticipatory anxiety. Then there's obviously another duration. Okay, DSM-5-TR requires that it should be for at least 1 month that there is persistent concern about additional panic attacks or significant maladaptive changes in the behavior because of the panic attacks. Okay, so let's understand what do we mean by how is panic attack different than the panic disorder, or is it the same? So when we say that panic disorder and panic attack are different, how can we understand this? Let's understand this with a very simple analogy. Think of a fever. Okay, now fever is a symptom. Many illnesses have fever, like viral infections, malaria, typhoid, dengue. Similarly, panic attack is a symptom. It can occur in many mental health disorders. But when we talk about panic disorder, it is a diagnosis. Okay, why? Both involve the same physical symptoms. The person will experience palpitations, sweating, trembling, shortness of breath, chest discomfort, feeling of choking, dizziness, things like that. So symptoms alone cannot differentiate it, right? So that is why we cannot just focus on reading the first line of the case. We also need to see where the difference lies. A panic attack can occur in a lot of disorders. It could occur in panic disorder, obviously, PTSD, social anxiety disorder, specific phobia, even some medical conditions. So, seeing a panic attack doesn't automatically mean panic disorder. For panic disorder, DSM-5 asks another question. What happened after the attack? What happened after the attack? Did the person develop a constant worry, which is persistent in nature? Did their behavior change? If yes, now we are thinking about a panic disorder. Okay, so we already said panic attack usually lasts for a few minutes, reaching its peak very, very quickly, while panic disorder, the persistent worry, the concern, the behavioral changes should at least be for 1 month or more. Okay, let's compare these two people, Rohit and Ananya. Okay, so this person has one panic attack before an important interview. Okay, never experiences another attack, no behavioral changes. Would you diagnose it as a panic disorder? No. Not the other person. They experience repeated, unexpected panic attacks, stops traveling alone, avoids crowded spaces, constantly worries, what if another attack happens? Now we are dealing with panic disorder. Right? So whenever you read a case, don't immediately label it as a panic disorder. You need to ask, was the panic attack unexpected? Has the person been worried about having another? And has this concern lasted for at least 1 month? Remember, panic attack is a symptom, panic disorder is a diagnosis. Okay, now let's move on to another disorder, one of the most commonly misunderstood anxiety disorders, agoraphobia. So if I ask people outside this classroom what agoraphobia is, most people would immediately say, this is a fear of open spaces. Are they wrong? It's simply oversimplified, if I have to say that. Agoraphobia is the fear of anxiety about situations where escape might be difficult, or help might not be available if panic-like symptoms occur. Notice that the fear is not really about the place itself. It doesn't matter where the person is. The fear is about unable to escape or unable to get help. So the person isn't thinking, I'm scared of shopping malls, as we discussed in the last example. They're thinking, what if I get a panic attack in this shopping mall and I can't get out? That is the real fear. What if something happens and I can't get out of this shopping mall? So there are 5 fear situations according to DSM-5. First one is using public transport, buses, trains, metros, airplanes, anything. Second is being in open spaces or enclosed public spaces, like it could be shopping malls, movie theaters, supermarkets, parking lots, anything. Third is being in enclosed spaces. We already talked about shops, theaters, elevators, right? Fourth is standing in line or being in a crowd, concerts, festivals, busy railway stations, anything. And being outside the home alone, walking alone, traveling without a friend, a family member, things like that. So just remember, the common idea is that escape feels difficult or help feels unavailable. Okay, now here is an important DSM update. Agoraphobia was usually linked to panic disorder in DSM-4. Even a lot of students mistake this. DSM-5 has made agoraphobia an independent diagnosis. This means that a person can have agoraphobia without actually having a panic disorder. So, in the same way, a person can have a panic disorder without having agoraphobia. These two disorders frequently occur together but do not have the same diagnosis. Okay. Now let's move on to specific phobia. Now we have seen anxiety related to difficult to escape situations like agoraphobia. Let's look into the disorder where the anxiety is much more specific, about a particular object or about a particular situation, specific objects or specific situations. So specific phobia is characterized by marked fear or anxiety about a specific object or situation, leading to individual actively avoiding it actively avoid it or endure it with intense distress. The fear is out of proportion to the actual danger. So everyone, like most of the people, are very cautious around snakes. If a snake jumps on you, you are gonna fear it. Okay, but if someone even refuses to enter a garden because they fear that there might be a snake, even when it's let's just say, even if it's a home garden, okay, there is no evidence that of the presence of a snake, so that fear becomes excessive and irrational. Okay, now there are 5 types of specific phobia. First is animal type. Animal type includes the fear of animals like dogs, snakes, spiders, insects, birds, and it usually begins in the childhood. Usually. It can happen in adulthood as well. One of the examples, remember this as well, fear of spiders is called arachnophobia. Second is natural environment type. These involve elements of nature such as heights, storms, water, lightning. So a person may completely avoid trekking or traveling because of this fear. Fear of storms is called astrophobia. Okay. Now third is blood injection injury type. This is actually a very unique subtype. Unlike most of the anxiety disorders where heart rate increases, here actually they experience a vasovagal response. What they experience is a vasovagal response. What happens in this response is that there is a sudden drop in the heart rate or sudden drop in the blood pressure, which could actually lead to fainting. That is why you might have heard of a lot of cases where someone fainted due to during a blood test or while watching somebody get an injection. Okay, so it is a vasovagal response. Remember. Then we have situational type. The fear is linked to specific situations like driving, flying, elevators, tunnels. Notice that agoraphobia had the fear of escape. Here it's about the situation. It's not about the escape. Okay. Now the other type is basically saying includes fear that did not fit any of the previous groups. It could be about loud sounds or jokers, costumed characters. See, we are talking about fear of vomiting, emetophobia. Okay. So regardless of the subtype, the treatment approach remains largely the same. The difference is what the person fears, not how the disorder develops. So if a person avoids elevator because they fear elevators themselves, what would be the diagnosis? Specific phobia, especially situational type. But what if they avoid the elevators because they worry they might have a panic attack and they won't be able to escape? That is agoraphobia. Okay. Now these three disorders of anxiety disorders, we'll look into them very briefly by answering one question. What exactly is the person afraid of? Once you answer that question, the diagnosis becomes clear. Let's first look into social anxiety disorder or social phobia. Here the person is not actually afraid of people. They are afraid of being judged, being embarrassed, being criticized, being negatively evaluated by others. So, for an example, if there is a student who knows the answer in class but refuses to raise their hand, why? Because they are thinking, what if I answer incorrectly and everyone laughs at me? Okay. Or if someone is avoiding to give a presentation or interview or public speaking or even eating in front of others because they fear embarrassment. So here the core feature is negative evaluation. Negative evaluation. Now, when we talk about the separation anxiety disorder, how is it different? Here, the fear is nothing to do with social judgment. In fact, it's about being separated from an attachment figure. In children, it's usually a parent. In adults, it could be your partner, your husband, your wife, or any other family member, even friends for that matter. So, for an example, a child cries every morning before going to school. Why? Because they're terrified that something bad will happen to their mother while they're away. Or as an adult, if someone is constantly worried about that their partner might have an accident whenever they leave home. So the anxiety is revolving around separation, not the social situations. Separation. The third is selective mutism, one of the most misunderstood disorders again. The child can speak normally. Okay, there is no language problem, there is no intellectual problem that is happening here. And the child constantly fears to speak in specific social situations, despite they can speak comfortably in front of in other situations. So, for an example, a child is who continuously talks at home with the parents, with their family members, but is completely silent at school. That could be a feature of selective mutism. The silence is occurring only in particular settings. So we need to look into what the central fear is. Fear of negative evaluation, social anxiety disorder. Fear of separation anxiety disorder. Failure to speak in specific settings despite normal speech elsewhere. Selective mutism. So here you can see there is, now that we have covered all the anxiety disorders, here is the summary. What I would like you to do is take a screenshot of this table. This table is designed to basically help you think what to look at for the correct understanding of the diagnosis. You ask 3 questions. What is triggering the anxiety? Is there any important duration criterion? And what is the hallmark feature? Okay. Each 7 disorder answers a different question. What if something goes wrong? GAD. What if I have another panic attack? Panic disorder. What if I can't escape? Agoraphobia. What if I encounter this particular object? Specific phobia. What will people think of me? Social anxiety. What if I'm separated from them? Separation anxiety. I can speak but not hear. Selective mutism. These are the central fear. Recognize it, diagnosis becomes easier. Now, let's talk about how you can actually attend the mock test for this particular session. So, again, you click on the link that is provided below. What you have to do is you have to enter your name, you have to enter your email address, and then you have to enter the test code for this particular session. The test code is AJ876. The test code is AJ876. And remember, do not leave spaces while entering your email addresses or the test code. Okay? Attempt the mock test to gauge your understanding, and remember, it is okay if you're not able to, attempt all the questions correctly. It is to understand what you have gained and practice what you have not been able to. Okay, with this that we have done with anxiety disorders, we'll move to another very important DSM-5 chapter, obsessive compulsive and related disorders, very often abbreviated as OCRDs. Okay, so many students assume that OCD is simply another anxiety disorder. We already talked about it. Yes, anxiety is a major part of OCD. However, why it is not classified anymore under anxiety disorder? Because the core symptom is not fear or anxiety. Okay, the core symptom here is obsessions and compulsions. Anxiety is a secondary symptom here. The person is experiencing intrusive thoughts, images, or urges. That's the obsession. And then to reduce the anxiety caused by those obsessions, they perform repetitive behaviors or mental acts, compulsion. Let's look into what disorder comes under this first. So first is obviously OCD, obsessive compulsive disorder. Then we have body dysmorphic disorder, clothing disorder, trichotillomania, and excoriation, also known as skin picking disorder. Trichotillomania is also known as hair pulling disorder. Hair pulling disorder. Okay. So, although these all disorders look very different, they all share one important feature: repetitive thoughts or repetitive behaviors that are difficult to control. Now that we know what disorders belong to this chapter, let's move on to something which is something that we have to know is the OCD cycle. Okay, because almost every OCD symptom follows the same pattern. Okay. Now, notice something. Okay, notice something that OCD is not just about washing hands or checking for locks. It is actually a self-perpetuating cycle. Self-perpetuating cycle. What do we mean by that? What we mean is that one stage leads to the next, and unfortunately, every time the cycle repeats, it becomes stronger. So the first step is obsession. What is an obsession? Obsession is an intrusive, unwanted, recurrent thought, image, urge that repeatedly enters the person's mind. One important point here to note is that the person does not want these thoughts. For example, there are thoughts like, what if my hands are contaminated? Or what if I accidentally, harmed someone? Or, oh my God, what if I forgot to lock the door? Okay, these thoughts are distressing because the person usually recognizes that they are irrational, they're exaggerated. So the person is not choosing the thoughts, they are just intruding. Okay, that is why they're intrusive, they're unwanted. Okay. The second step after this obsession is anxiety. Okay, naturally, these intrusive thoughts create a feeling of anxiety, a distress. So when someone keeps on thinking that my hands are contaminated, their anxiety continuously increases till the point that they feel that they have to do something to reduce it, to reduce this feeling of, what if my hands are contaminated? Okay, that is where the third step comes in, compulsion. So, what do they do to reduce the anxiety? They perform a compulsion. What is a compulsion? A compulsion is a repetitive behavior or a mental act performed to reduce this anxiety or to reduce something bad from happening. So it could be, repeatedly washing hands, repeatedly checking for doors, counting. It could be arranging objects. It could be even silently praying, repeating phrases mentally. So remember that compulsions are not just behaviors. It is also sometimes just mental acts like praying, like repeating phrases. Okay, not just a behavior. Now, what happens when you perform these compulsions? There is a feeling of temporary relief. The person's anxiety decreases. They feel relaxed. But the important term here is temporary. Why is it temporary? Because the relief does not last. Soon, another obsession will appear and the cycle will start all over again. Why does this happen? Why does the cycle start all over again? That is because of the fifth step known as negative reinforcement, which is one of the most important psychological concepts about OCD. Why does OCD continue? Because of this one. Let's understand this properly, okay? The compulsion removes something unpleasant. What is it removing? The anxiety. So, whenever a behavior is removing some unpleasant feeling, that behavior becomes more likely to occur again. Why will it occur again? Because it got negatively reinforced. So, whenever I wash my hands, my anxiety reduces. Okay, as a result, I'll wash my hand even more the next time. So now the compulsion isn't even reducing OCD, it is actually strengthening it, okay, because of the temporary relief. Okay, let's put this whole cycle together. Okay, imagine someone touches the doorknob, okay, to open the doorknob. Now they think that my hands are contaminated, the obsession. Now it makes them extremely anxious. To reduce this anxiousness, they go and wash their hands for 20 minutes. Their anxiety decreases. Okay, what did we learn? Hand washing works. So next time when the obsession returns, the cycle repeats. It is negatively reinforced. So it is actually negative reinforcement that actually maintains OCD. Okay, it's not positive reinforcement, it is negative reinforcement, commonly asked in a lot of examinations. Okay, anxiety is removed after the compulsion. Removing something unpleasant increases the behavior, therefore it is negatively reinforced. Now let's understand the difference between obsessions and compulsions. Okay, I'll start with a question. If someone is supposedly repeatedly washing hands, what is the obsession? Washing hands or something else? Washing hands was not the obsession. It was actually the thought behind washing those hands. Why would they wash their hands repeatedly? Because the thought is the hands are contaminated. That thought is actually the reason behind hand washing. So that thought is the obsession. We already discussed this. Obsession is recurrent, intrusive, unwanted thought. 3 important words here. Intrusive and unwanted are the first two. Intrusive, it enters your minds automatically. Unwanted, person does not enjoy these thoughts. Now, another term that you need to remember is ego dystonic. What is ego syntonic and ego dystonic? Ego syntonic means whatever a thought is, it is consistent with the person's own belief and values. Okay. But when it is ego dystonic, it is inconsistent with your beliefs. It is inconsistent with your values. Okay. So, for an example, what if I accidentally hit someone while driving? This is my thought. Okay. The person realizes that they don't want to think this way. That is why the thought is distressing. Now, what is compulsion? It is response to the obsession to reduce the anxiety. So, when the person thought, I forgot to lock the door, the compulsion becomes that they want to check again and again that if they lock the door. Thought is first, which is obsession. Behavior is, or a mental act is second, which is the compulsion. Okay. If this is happening inside the person's mind, obsession. If the person is doing something, even in their mind, to reduce that anxiety, it's a compulsion. Important misconception. We already talked about compulsions can be mental, repeating words, counting, praying, reviewing of events. Okay. Let's move on to the themes or the subtypes. Okay. What is the actual presentation of OCD? Is it only of one type? No. It could be of different types. So, the first one is the contamination, one of the most known one. Okay. The obsession involves thinking about contamination by germs, dirt, chemical, bodily fluids. So, again, what if my hands have dangerous virus, dangerous bacteria? What if I spread an infection to my family? To reduce this anxiety, they can wash their hands, avoid touching things like door handles, or excessively clean the home. So the fear is contamination. They don't just like cleanliness, they fear contamination. Okay. The second is harm or checking. Okay, it's about safety. So here the obsession is about causing harm to others, either intentionally or unintentionally. Okay, so for an example, it could be like, what if I forgot to switch off the gas? Or what if I hit someone while I'm not driving carefully and I didn't even notice? Okay. Now what will happen is the compulsion will, usually surround for checking. They'll check excessively doors, gas doors, electric appliances, over checking for, car mirrors. So they will do this dozens of times. That is what this is about. Third is symmetry or ordering. Now some individuals just feel this intense need for things to be perfectly symmetrical, perfectly balanced, just right. Okay, the books should be aligned exactly, pens should be kept parallel, frames should be perfectly straight. Even if something feels off, they experience the feeling of anxiety and it cannot stop until it's corrected. It's not perfectionism, it is driven by anxiety. Remember that. Fourth is forbidden thoughts. What do you mean by forbidden thoughts? This is something that actually people do not recognize. Here what happens is the person experiences intrusive thoughts that are violent, that are sexual, that are religious in nature. Like, examples could include, what if I hurt my child? Or what if I shouted something offensive in a temple? Or what if I push someone onto the railway tracks? The thoughts are ego dystonic. The person is deeply disturbed by them. They do not have any desire to act upon them. Okay, that is important. They don't want to do it. They just have this intrusive feeling that what if they end up doing it? Now, we talked about Tsiolkovsky's model here. Basically, what this model says is that, person with OCD have this inflated sense of responsibility. Okay, they believe that, they're personally responsible for preventing harm from happening. Like, most people would think, I probably locked the door. But a person with OCD would think, if I don't check one more time, if I locked the door or not, someone will get hurt and that would be my fault. Okay, moving on to some other OCD disorders which we are going to cover very, very briefly is body dysmorphic disorder. Okay, now this disorder, the individual becomes preoccupied with one or more perceived flaws in their physical appearance. Remember the term perceived defects, perceived flaw. This defect may be very minor, not even noticeable by someone else, but to individual it is extremely real, it is extremely distressing. Okay, now because of this preoccupation, because of this distress, they will constantly check mirrors, they will compare themselves with others, they will seek repeated reassurances, they even might spend hours fixing it, hiding it. So some people even avoid social situations because they believe that people might start staring or judge their appearance. Okay, you can look into the assessment, the treatment as well. Now, hoarding disorder is something very different. Okay, the problem is not the appearance. It is actually that there is a persistent difficulty with disregarding things, with disregarding something you possess. Okay, regardless of what value it carries. It could even be something as useless as an old newspaper or a broken electronic or empty containers. Things like that. Even a used paper, that they'll hoard it. Okay, over time there would be excessive accumulation of objects that creates clutter that interferes with their normal living. Rooms can become unusable because they are filled with stored items, and they will keep on believing that, oh, I might need this someday, and if I throw it away it would be a mistake. How can we assess this? We have SIR. There's also treatment focused on CBT. There is skills training. You can look into it more. Now we'll do the last two disorders of OCD, which is trichotillomania and excoriation disorder. Trichotillomania is known as hair pulling disorder. Okay, what happens here is there is this recurrent urge to pull out one's own hair, resulting in noticeable hair losses. How can it be pulled? It could be pulled from your scalp, from eyebrows, from eyelashes, even from your body. Okay, many people, describe this as a growing sense of tension because before they end up pulling something and feel a relief. Okay, but despite several attempts, they find it very difficult to stop. Then we have excoriation disorder. Now here what happens is instead of pulling your hair out, they pick on their skin. It could lead to cuts, it could lead to sores, scars, even infections. Okay, but there is usually an urge before the behavior and temporary relief afterwards. So if they do not perform it, they feel anxious, and the moment they perform it, they feel better. Okay, now so important thing that you have to remember here is that although these disorders do not always involve classic obsessions or compulsions like OCD, they share a common feature: repetitive behavior that is very difficult to control. That is why it comes under OCRTs. Okay, so there is this term that you should know, which is body focused repetitive behaviors. Body focused repetitive behaviors. This term simply means that repetitive behaviors is directed towards your own body. Okay, and it can co-occur with OCD and anxiety. Now that we are done with obsessive compulsive disorders, we are going to look into trauma and stress related disorders as well. So in trauma and stress related disorders, you have to remember that one thing that is in common is an identifiable stressor or a traumatic event. The event comes first and then the psychological symptoms develop afterwards. There is PTSD, acute stress disorder, adjustment disorder, reactive attachment disorder, disinhibited social engagement disorder. And there is one disorder that is missing. There's a reason that I have not mentioned it here, because I mentioned it in the changes of DSM. There has been added one, which is prolonged grief disorder, right? It has been added recently. Remember that. Okay, great. So we are going to discuss these disorders in detail, but you also should know that there is something called complex PTSD that is only mentioned in ICD-11. We'll also discuss this briefly further. So let's first discuss PTSD. Okay, remember that you do not have to memorize long symptom lists. What I need you to remember when it comes to PTSD is four important clusters. But before that, what PTSD is? PTSD is basically post-traumatic stress disorder. As the name suggests, it develops after there is an exposure to a traumatic event, which can actually involve an actual or threaten death, a serious injury, sexual violence, anything. Like it could be a road traffic accident, a natural disaster, a physical assault, a sexual assault, wars, combats, terrorist attacks, So you have to remember that not every stressful event leads to PTSD, okay? The trauma must meet the DSM criterion. So what are the four symptom clusters? DSM-5-TR groups PTSD into four clusters. The first one is intrusion. When I'm talking about intrusion, I'm saying that this traumatic event keeps on coming back into the person's mind, even when you do not want it to come back. It can happen as distressing memories, nightmares, flashbacks, or intense emotional distress that reminds you of the trauma. Okay, but it will keep on coming back despite you do not want to remember it. So, like suppose a survivor of a road accident, he was screeching of brakes. Okay, and immediately feels that they're back to the time when the accident was happening and it's happening all over again. That is intrusion. Second is avoidance. Now, since the memories are so distressing, the person begins avoiding them, avoiding in fact anything that could be related to the trauma. They could avoid people, they could avoid those places, they could even avoid conversations, even thoughts, even feelings. So let's just say if someone was assaulted in a mall, okay, they might completely avoid going to a mall for months. Okay, then we have negative cognition or mood. Actually, this is where the cluster includes changes in how the person thinks and feels after the trauma. Okay, the feelings include there is this persistent feeling of guilt or feeling of detachment from others, loss of interest in activities, or there could be negative beliefs like the world is not at all safe. I can't trust anyone ever again. It could be I'm never gonna talk to this I'm not, so in case of sexual violence it could be I would never talk to this opposite gender ever again. So this cluster is very important. It is more oftenly overlooked but is very important for the diagnosis. Now, hyperarousal. The question recently came in an M.Phil exam from this, like hyperarousal is related to which disorder? Remember, PTSD. What do we mean by hyperarousal? It means that person's body stays in this constant state of alertness. Okay, they're always hyper vigilant. They are startled very in a very exaggerated way, very easily as well. They're irritable, they're not able to sleep properly, there is difficulty in concentration. So this could be like there is this combat veteran, okay, who's constantly scanning the environment for looking for danger, and even jumps even with a slight amount of sound, like if this pen falls, it will startle them. Okay, that is hyper arousal. So now this was the first criteria. Now let's look at the duration. Now, these symptoms must be present for more than 1 month. What will happen if it's present for less than 1 month? Is it not a disorder? We'll look into it, okay. The assessment is PSL-5, okay, known as PTSD checklist for DSM-5. Okay, it's a self-report questionnaire. Again, it's an assessment scale, not a substitute. Now, something that we need to know in very brief is Ehlers and Clark model. It's a cognitive model. It basically says that people with PTSD continuously experiencing symptoms because they perceive the trauma as ongoing, is current. The trauma has not stopped, is not in the past, it has not ended. They feel like it's still going on, it's still in the present. Okay, that is what Ehlers and Clark model uses to explain PTSD. Okay. Now let's move on to acute stress disorder. Okay. In acute stress disorder, what we are saying is that it's not about the severity of the symptoms. Okay, it is actually about how long the symptom lasts. So it has the same, symptoms as a traumatic event like serious accidents, natural disaster, physical assault, sexual assault, war, combat, things like that. And even the severity could be the same. A traumatic event happens and symptoms begin almost immediately. However, for a diagnosis of acute stress disorder, this lasts from 3 days to 1 month. 3 days to 1 month, and the trauma resolves itself. Okay, if the the symptoms persist beyond 1 month, we consider it being PTSD if other criteria are met. Okay, so think of ASD as an early phase of the trauma, while PTSD as a persistent symptom. Okay, so if a person who was in a road accident and 5 days later they're experiencing nightmares, flashback, they avoid the situation, they're hypervigilant. Now, if these symptoms are present for 2 weeks, ASD. If these symptoms are present for 2 months, PTSD. Okay, one thing that we need to remember is when it comes to PTSD is whatever we discussed right now was about adults. What about children? Huh? So, let's talk about PTSD in children. Okay, PTSD in children. Now, when it comes to PTSD in children, DSM-5 says that slightly different considerations for children for which are 6 years and younger. 6 years and younger. Okay. So, children do not always express their trauma the same way adults do. So, there are 3 features. Obviously, there is recurrent distressing memories. It comes with social withdrawal and sleep disturbances or irritability. So, instead of describing their intrusive memories, they may actually reenact them through traumatic plays. They could make drawings of it, or try to play it out, or things like that. So, and you can also notice symptoms like they are extremely irritated, their temper tantrums, they're more clingy, there's regression in their behavior, there's social withdrawal, there is reduced interest in playing. Okay, and even nightmares occur. So, it appears a little differently than what we will see in adults. Remember that. Remember the reenactment of traumatic event. It could be through play, through drawings, some other way. It's always there. Okay, great. So now we have done PTSD, we have done acute stress disorder. We have also discussed how PTSD is different from ASD. Okay, versus the duration, the courses, everything. It's different. Begins from 3 days to 1 month. Okay, it's not the severity. It's actually the duration. Okay, great. So let's move on to the difference between complex PTSD, which is ICD-11. It is not in DSM-5. Triad, remember that. Okay. So how is it different from adjustment disorder as well? Okay, let's first understand complex PTSD. Now that we understand what PTSD is, which is a single traumatic event, a road accident, a natural disaster. But what if this trauma is repeated again and again and again? It's prolonged. It's something that you cannot escape. Like childhood abuse, sexual abuse, or domestic violence, some kind of torture, human trafficking, long-term captivity, prisoners of war. These situations is something that we call complex PTSD. Okay, the person still has the core symptoms of PTSD like intrusion, avoidance, negative mood and cognition, hyperarousal. They have all those symptoms, all the 4 symptoms. But they also have 3 broader disturbances. What are those? First is affective dysregulation. Affective dysregulation means there is difficulty in regulating their emotions. Okay. Then there is negative self-concept, feelings like, I'm worthless, this is my fault, things like that. And difficulty in relationships. They're not able to form relationships. They're not able to maintain relationships. Okay, so it's basically, what is complex PTSD is? It is PTSD plus disturbances in self-organization. Remember the term self-organization. Okay. So, again, complex PTSD is recognized in ICD-11, not a separate diagnosis in DSM-5. Now, let's compare this with adjustment disorders. Unlike PTSD, the stressor does not actually have to involve an actual or threatened death or a serious injury or sexual violence. It develops to very ordinary but very significant life stresses. Ordinary but significant life stresses. Okay, it could be a divorce, a breakup, a job loss, a financial problem, academic failure, relocation. Okay, so they do not actually qualify as traumatic events, but they're very stressful experiences. Here what would happen is the person would experience emotion or behavioral symptoms that is out of the proportion to the stressor and impact their functioning to another level. So if two students face the same exam, one is just disappointed and gradually recovers, but the other struggles, they're extremely distressed, stop attending classes, withdraws socially, struggles to symptom. This could be one of the considerations. I'm not saying this is the disorder, I'm saying this could be one of the considerations. Why? Adjustment disorder is a non-traumatic life stressor, disproportionate to the stressor, does not require exposure to the trauma. Now, what are the other trauma or stress-related disorders that we haven't discussed, right? So, before moving on to epidemiology and high-yield facts, which I would like you to take a screenshot of, because these are something that is very commonly asked in exams, lifetime prevalences, gender differences, ages of onset. Okay. So actually remember that you don't need to remember each and every term, but here especially what you basically need to remember is, which is more common, which is more, which occurs when, kind of things. But here are some disorders that we have not discussed that I would like you to mention. I would like to discuss this in a little brief. Let's start with reactive attachment disorder, RAD. Okay. So when we talk about reactive attachment disorder, okay, we are saying RAD. We are saying that this occurs in children who experience severe neglect, severe abuse, or there is repeated changes in caregivers, or there is institutional upbringing. So what they do is, instead of seeking comfort when they are distressed, what they do is they become emotionally withdrawn. That is the main feature. Okay, they rarely seek comfort from anyone, from caregivers, and they even rarely show any kind of positive emotions. The whole problem here becomes is failure to form secure attachments. Failure to form secure attachments. This is what RAD about. So what is DSED about then? Now DSED is a different disorder, but it is something that you can understand as the opposite of RAD. Okay, this inhibits social engagement disorder. So instead of withdrawing, they become over familiar with strangers. So suppose there is a child, they even may leave with an unfamiliar adult or hug strangers without hesitation. Remember, DSED is over friendly, over familiarity. RAD is withdrawn. Now there is another disorder. We have already discussed this before. Again, very brief. Prolonged grief disorder, PGD. Prolonged grief disorder. What happens is, experiencing grief after losing someone is normal. However, when this grief persists beyond what is culturally expected out of that area, of that period, okay, it is causing significant impairment. That is when we consider prolonged grief disorder. It's like a person is emotionally stuck in that loss and struggles to resume their normal life. More than 12 months in adults, more than 6 months in children. Simple, short. Now that we are done with all the PTSD, stress and trauma related disorders as well, there are two things that we are going to do in very fastly. Also, when I say very fastly, take a screenshot. These are mostly things that you have to remember. Remember that always it begins with psychological treatments. Okay, the first line psychological treatment for most anxiety disorders is cognitive behavioral therapy. Okay, CBT helps individuals in identifying and challenging those unhelpful thoughts while gradually changing the behavior that is maintaining the anxiety. So a person with GAD learns to identify excessive worry and stress and how they can tolerate the uncertainty. Someone with panic disorder can learn how to deal with the physical symptoms, and these physical symptoms are not that dangerous. Things like that. But OCD is a little different. Although CBT is still a treatment of choice, it uses a very specific technique known as ERP. Prolonged exposure I have mentioned here. It is also called ERP, exposure and response prevention. In ERP, the individual is gradually exposed to the feared situation without performing the compulsion. So over time, the anxiety naturally decreases and the OCD cycle that was formed weakens. Focusing on medication, the symptoms are moderate to severe. Medication might be recommended alongside psychotherapy. The most commonly prescribed is SSRIs, like sertraline, and we also have fluoxetine, escitalopram. Now, these medications help you reduce the symptoms of anxiety, OCD, PTSD. In some situations, we also give SNRIs for anxiety disorders particularly. It is important to remember that medication is usually combined with psychotherapy. It does not replace it. Again, remember, the first line treatment is always CBT. It is always CBT, and if it is OCD, it is CBT with ERP, exposure and response prevention. Okay. Now that we are done with this, let's also look in short the assessment scales. So when it comes to GAD, we have GAD 7, right? Which is a brief self-report for use in clinics. We also have HAM-A, Hamilton Anxiety Rating Scale, which is a clinician rating scale. When it comes to panic disorder, we have PDSS, Panic Disorder Severity Scale. Take a screenshot, as the name suggests. It helps assess how severe the panic symptoms are and how much it affects the daily functioning. OCD, Y-Box, Yale-Brown Obsessive Compulsive Scale. One of the most famous OCD assessments, one of the most important assessments to remember as well. Post-traumatic stress disorder, PCL-5, PTSD checklist for DSM-5, self-report measure again. Social anxiety disorder, LSAS, Leibovitz social anxiety scale, evaluates both fear and avoidance across different social situations. Now that we have completed anxiety disorders, obsessive compulsive related disorders, and stress and trauma related disorders, let's test what you have learned. This you have to follow the same order. I read the question, you pause the video, answer it yourself, then I tell the answer, you match whether you were able to actually gauge it or not. If you were, that's good. If not, go and revise that slide. It is easy. You will be able to do it. Question number 1. A 26-year-old woman reports excessive worry about finances, family, work performance, and health for the past 8 months. She finds it difficult to control the worry and experiences muscle tension, fatigue, poor concentration, and disturbed sleep. Which diagnosis is most appropriate? A. Panic disorder, B. GAD, C. Social anxiety disorder, D. Adjustment disorder. The answer is B. Generalized anxiety disorder. Why? It's not one area, it's different areas. That was the first hint. Past 8 months. Second hint. Difficult to control worry and experiences, muscle tension, fatigue, poor concentration. We need the symptoms, right? So, does it fulfill all the DSM criteria? It does. That is why GAD. Second, obsessions of obsessive compulsive disorder may present as A. Hallucinations, B. Delusions, C. Mental images, and D. Panic attacks. The answer would be C. Mental images. Hallucination disorders are psychotic features. Okay. How does obsession present itself? Through mental images. These are intrusive, right? So it could be in terms of mental images. Panic attack is absolutely different. It's intense, sudden, unexpected fear, which peaks within minutes. Remember? Question number 3. Which of the following is not a symptom of post-traumatic stress disorder, PTSD? A. Hypervigilance, B. Avoidance of trauma-related stimuli, C. Obsessive compulsive hand washing, and D. Intrusive thoughts about the traumatic event. The answer would be C. Compulsive hand washing. Why? This is feature of OCD. It's a compulsion. Hypervigilance is a feature of PTSD. Avoidance of trauma-related stimuli, again. Hyperarousal, avoidance. Intrusive thoughts, intrusion. The 4 clusters. Remember? Then there is negative cognition and mood, the 4th one. Question number 4. How does post-traumatic stress disorder typically manifest in children aged 6 years or younger? We talked about this. A. Socially disinhibited behavior. B. Frequent tantrums and play and reenactments of the trauma. C. Obsessive cleaning rituals. And D. Compulsive hair pulling. The answer would be B. Why? We already said it presents itself in a different way. They tend to reenact whatever happened through plays, through drawings, and they're irritable. They have temper outbursts, right? Okay. Question number 5. Which of the following is true about obsessional thoughts? A. They are best treated by thought stopping. B. They always give rise to compulsions. C. They are ego dystonic. D. They are rarely of a sexual nature. The answer is C. They're ego dystonic. You already said the thought does not match the person. Okay. their beliefs, their ideations, their values. Now, they're best treated by thought stopping. Thought stopping? Can you just treat it by thought stopping? No, right? Just thought, stop your thought. No. Always right, if an obsession is controlled, it does not give rise to an anxiety. It won't lead to compulsion. They're rarely of sexual nature? No. Actually, a lot of these obsessions are of sexual nature. Okay, with this, we are done with our module 2. We have completed most of the disorders. We are left with some of the disorders that we will be covering under module 3. Okay, till then, attend the mock test to revise what we have done, and we'll meet you soon for the module 3. Hope you join us. Okay, till then, bye-bye, take care.